Periodontitis refers to the inflammation of the supporting periodontal tissues surrounding the tooth. It is caused by specific groups of microorganisms and results in progressive destruction of the periodontal fibers and the alveolar bone. Chronic periodontitis is the most common form of periodontitis, has a slow rate of progression, and most commonly affects adults and sometimes even children and adolescents. It is associated with accumulation of plaque and calculus, but the rate of disease progression also depends on local, systemic, and environmental factors. Aggressive periodontitis, on the other hand, differs from the chronic form by occurring primarily in adolescents and young adults, causing rapid destruction of periodontium with very little or no plaque and calculus accumulation, occurring in healthy individuals with no systemic disease, and having a genetic predisposition. Aggressive periodontitis is further classified as localized aggressive periodontitis and generalized aggressive periodontitis. As the name implies, the localized form of the disease is characterized by destruction of periodontal tissues and bone loss localized only around the incisors and the first molars. Generalized aggressive periodontitis, however, has a more generalized, widespread destruction. The localized form of the disease was previously called localized juvenile periodontitis, and the generalized aggressive form encompasses what were previously called generalized juvenile periodontitis and rapidly progressive periodontitis. So the pathogenesis of aggressive periodontitis is attributed mainly to microbiological factors and genetic predispositions to certain immunologic abnormalities. So although specific microorganisms like Porphyromonas gingivalis, Prevotella intermedia, Capnocytophaga species, and Eikenella corridans have been reported, Aggregatibacter actinomycetum comitans is thought to be the primary pathogen involved with the disease. So why do researchers believe actinomycetum comitans to be the primary pathogen causing the disease? Well, for starters, almost 97% of patients with this disease harbor a very high number of Aggregatibacter actinomycetum comitans. Compared to this, only 21% of patients with chronic form of periodontitis may harbor this microorganism. Another interesting fact is that localized aggressive periodontitis patients show elevated level of this organism in sites of destruction or disease progression compared to the low numbers or complete absence in other healthy sites. Localized aggressive periodontitis patients have elevated serum antibody levels against actinomycetum comitans. It has also been found that reducing the load of Aggregatibacter actinomycetum comitans in patients during treatment correlates positively with clinical success of the treatment. So how does this microorganism cause the disease? Well, first of all, Aggregatibacter has the ability to translocate itself through the junctional epithelium, invading into the connective tissue. So just scaling or root planing to remove plaque or diseased and inflamed periodontal tissue is not going to solve the problem. Now, one of the main weapons in its arsenal is a protein toxin called leukotoxin. Now, leukotoxin helps Aggregatibacter actinomycetum comitans thrive in this microenvironment. So, leukotoxin can potentially kill neutrophils, which form the first line of defense in an inflammatory response. It can also cause non-lethal suppression of lymphocytic activity. Aggregatibacter actinomycetum comitans release chemotactic inhibitory factors that inhibit the ability of neutrophils to respond to chemotactic factors. This prevents neutrophils from migrating to the diseased site. The microorganism releases factors that help it evade the host immune response. And apart from causing havoc to the host immune response, the bacteria also produce collagenases that destroy the connective tissue and bone-resorbing factors causing a rapid resorption of bone. There is also the host inflammatory response to take into consideration. The host inflammatory response is elicited by bacteria and causes damage to the host tissues while trying to protect it. In fact, it has been reported that patients have hyperresponsive monocytes and macrophages which release bone-resorbing proteins like interleukin-1, prostaglandin E2 in excess, thus helping rapid bone resorption. Apart from the damage caused by this microorganism, individuals with this disease are also known to have genetic predispositions to immunologic abnormalities that could amplify the disease response. 70 to 75% of patients with this disease are known to have defective neutrophil chemotaxis. It was found that localized aggressive periodontitis tended to occur among family members, and the neutrophil defect had a genetic predisposition. Another defect in the localized aggressive periodontitis patients was that antibodies could not bind efficiently to bacterial antigens, which meant that these microorganisms could not be removed through complement-mediated responses. It is speculated for this reason that localized aggressive periodontitis patients tend to have a rather robust and increased antibody response to counter its inefficient binding to bacterial antigens.